So hi everyone, my name's Nurul. Nice to meet you all, and thank you very much for staying for the presentation today. So I'm Nurul. I'm a PhD candidate from Flinders University in the College of Nursing and Health Sciences. For those who don't know where Flinders University is, it's located in Adelaide, South Australia. So my research is a little bit different to the previous research. It's more on, I guess, COVID-19 and the critical care healthcare professionals, and surrounding the topics of burnout and well-being. So the title of my presentation today is about mitigating the impacts of COVID-19 on critical care. Can you hear me? Is that all right? Okay, yeah. So the research that I've done is an umbrella realist reviews of individual focus interventions. So before I get into, I guess, the nitty-gritty details of my research, I'll just give you a quick overview and background about critical care healthcare professionals and the concepts of well-being and burnout. So what is burnout and well-being? So well-being, there are several different definitions for well-being, but the one that I've used in this research is basically the ability to flourish, have a good life, and the ability to be healthy, happy, capable, and engaged. So I guess in terms of picturing this concept of well-being, you can picture it as a spectrum, where one end of the spectrum, you might have high well-being and you might have concepts such as happiness and flourishing. And as you go down towards the opposite end of the spectrum, you might find low well-being and concepts such as anxiety and depression. And with the definition for burnout, we've used Maslach and Leiter's definition of burnout, and it consists of 3 dimensions, including emotional exhaustion, depersonalization, and a lack of personal accomplishment. So burnout in critical care. So it's important to note that burnout doesn't only occur in critical care, but it occurs in healthcare professionals at large and globally. So there was a systematic review and meta-analysis that was conducted in 2021, and it demonstrated that about 52% of all healthcare professionals were suffering from burnout. So more specifically, the study showed that physicians and nurses had the highest rates of burnout, which is presented there, about 66%. That same study had also, measured the burnout rates pre-pandemic and during pandemic, and there was quite a significant amount of burnout pre-pandemic, which was about 32 to 34% of all healthcare professionals. But obviously, the COVID-19 pandemic has had a toll on healthcare professionals. It is also important to look at burnout in critical care healthcare professionals, because there are so many types of chronic stresses that they have to go through. There was a European-wide study that demonstrated that about 51% of ICU healthcare professionals were suffering from burnout during the pandemic, and pre-pandemic rates were about 25 to 30%. So when I talk about the different types of chronic occupational stresses, it could include things such as being exposed to high morbidity and mortality rates. Individuals might, encounter lots of ethical dilemmas. So all these different types of stresses have contributed to high burnout rates in critical care healthcare professionals. So the influences of COVID-19 on the healthcare system. So we all know that critical care healthcare professionals and healthcare professionals at large were at the forefront of the COVID pandemic. So they were forced to meet sudden and dramatic rises in workload and work demands. So namely the expansion of critical care healthcare provisions. So there were insufficient critical care units. So they had to open up more units to cater to patients who were suffering from COVID-19 and the effects of COVID-19 on them. So there were also other stresses that contributed to burnout, things such as the lack of protective equipment, contracting the virus, fears of passing the virus to their family, to their friends, and also the high rates of mortality. So COVID-19 had a huge toll on critical care healthcare professionals, and it had negative implications in terms of their mental health and physical health. Is that good? Yeah. Okay, so it had implications on their mental health and physical health. So there were quite a lot of studies that demonstrated individuals who were burnt out, mainly critical care healthcare professionals who were burnt out, had mental health disorders such as anxiety, depression, post-traumatic stress disorders, and also high rates of suicidal ideations. There were also physical health implications, so things such as having pains, digestive upsets, aches, and increased risk of cardiovascular diseases were also present. So the COVID-19 did not only have an impact on the individual, the critical care healthcare professional, but also society at large. Why? Because if the healthcare professional is affected by mental health and physical health implications from COVID, then it would also implicate to the safety and quality care provided to the patients. So this is where my research comes in, and basically with this research, I would like to determine what types of individual interventions, so things like personal resources that are available out there for critical care healthcare professionals to utilize in order for them to cope with their burnout symptoms or even normal chronic or normal stresses that they might encounter. So when we talk about interventions, interventions can be categorized as organizational interventions and individual interventions. So when I talk about organizational interventions, it includes things like leadership, supervisors, and performance feedbacks, whereas individual interventions are more of self-care, social support, awareness, and even mindfulness-based interventions. So it's important to also note that just because I guess we have individual interventions, we can't kind of like put the organizational aspects to its side. It needs to be done collaboratively, but due to, I guess, the time restrictions with my candidature, we had to just focus on one aspect, which is the individual interventions. So the aims and objectives of this research, the aim was to determine individually focused interventions for the promotion of critical care healthcare professionals' well-being and prevention of burnouts and its symptoms. So what I've done is an umbrella review, but not solely just an umbrella review, but I've integrated a realist evaluation in the umbrella review. And basically what it does is that instead of just figuring out what interventions are out there and mapping the interventions, I've also utilized a realist evaluation where it will allow me to kind of determine what interventions would work, for whom, how it might work, and under what conditions, so that we can actually design these kind of interventions solely specifically for critical care healthcare professionals. The objectives, before I go into the objectives, with the realist evaluation, it's important to note that it's more of theory synthesis, and to be able to do a realist evaluation, we need to consider the context, mechanisms, and outcome configuration. And basically, we might have an intervention, and so we need to determine what types of contexts were applicable to that intervention, and what kind of outcomes. Was the intervention effective or was it not effective? And then from there, we do a theory synthesis where we determine what the mechanisms are. So therefore, my objectives from my aims is to identify the mechanisms and outcomes of the interactions and determine the mechanisms that contribute to the outcomes. So my study methods, we had quite a few phases in terms of doing the methodology of this project, just because we've integrated the realist evaluation aspect of it. So the phase one was to actually construct an initial program theory. So usually in a realist evaluation, you would kind of find existing program theories that are out there. However, there were no program theories that catered towards critical care healthcare professionals and individual interventions. So we had to construct one. As you can see here, it's detailed in figure 1. I won't go into too much detail about it just because of the time constrictions, but if you do want to learn more or know more about the initial program theory and the overall research, it is published on BMJ Open, or you can find it on ResearchGate. So basically, the initial program theory talks about the types of resources, and it integrated middle range theories to be able to determine what types of resources would allow critical care healthcare professionals to thrive, flourish, and have vitality within the workforce. So after creating the initial program theory, we did a search of 7 databases. So included PsycInfo, Web of Science, Cyanal, Medline, Scopus, Clinical Trials, and ISRCTN. And we also did a citation search on Google Scholar and Web of Science just to make sure that we didn't miss out on any articles that are out there. Thereafter, we removed duplicates on EndNote, and then we uploaded all the articles onto Covidence. So in phase 3 and 4 is the selection criteria and data extraction phase. So in terms of our inclusion criteria, we initially had our population as critical care healthcare professionals. However, after we've searched through the 7 databases and citation search, we only determined one systematic review that included critical care healthcare professionals, not included, but had studies that were catered to critical care healthcare professionals. So what we had to do was that we had to expand our search to include all types of healthcare professionals. Our intervention was individual interventions, individual focus interventions, so things like mindfulness, interventions, self-care. Our comparator was either no usual practice, no intervention, or comparison between interventions. Our outcomes were well-being, burnout, compassion, satisfaction, mindfulness, resilience, and self-care indicators. When we initially conducted the search, we didn't have any time period restrictions because we wanted to include all types of interventions. But what we found from including all types of, systematic reviews was that there were multiple RCTs reported repeatedly throughout different types of systematic reviews. And so by putting a time constriction, time constriction in our inclusion criteria, it minimized that potential bias. The types of study included systematic reviews only, and we also had included an additional inclusion criteria, which was the quality appraisal. So we needed the studies to meet inclusion criteria number 6 and number 2 in the RM-STAR tool. So I'll talk about that a bit more in the later slides. So as you can see here, this is the Prisma flowchart. And so our initial search allowed us to get a total of about 4,467 articles. And the boxes, the orange boxes on the right, talks about the modification that we've done and when we did the modifications. And so we're left with a total of 17 included studies for our research. The quality assessment, with the 17 included studies, we did a quality assessment using the revised assessing and methodological quality of systematic reviews tool. And what I said initially was that part of our inclusion criteria was that we needed studies to meet inclusion criteria number 2 and number 6. So number 2 was that studies needed to have a comprehensive literature search, and criteria number 6 was that it needed to have an included studies table. Okay, I'll quickly. However, there was one study that didn't meet that criteria, and we've excluded it. Data extraction and analysis. So we had a predefined form where it was pre-tested, and then the predefined form had the context, mechanisms, outcomes. So we extracted the context and the outcomes, and then used middle range theories through discussions with the co-authors to determine mechanisms. The steps can be seen from 1 to 5 if you're interested. So after gathering the context, mechanisms, outcomes, what we then did was that we were able to use the context, mechanisms, outcome to create theory propositions, and then use the theory propositions to refine our initial program theory. So our results, from 16 systematic reviews, we determined that there were a total of 81 interventions, and I've categorized them into mindfulness, cognitive behavioral therapy, self-care, and coping strategies as seen in the PowerPoint. From this, we were able to determine 6 plausible hypotheses using the locus of control theory, the JDR, which is the job demands resources theory, and the self-regulatory model. And from these, these plausible hypotheses, it determined that if we wanted interventions to be to work and effective for healthcare professionals at large, it needed to encompass components such as tailoring, structured education, engagement with the intervention. So engagement both ways. It needs to be engaging to the participants, and participants need to be engaged to the intervention. It encompasses self-awareness. The interventions don't replace organizational or work stresses. So it needs to be a resource that helps instead of replacing. And we need to have a unified intervention and measures. So this is the refined program theory, but I'm running out of time, but you can have a greater detailed look in the publication. Study discussion, I want to bring your focus to two main components, which is the tailoring of individual interventions and the learning process. So for interventions to work, we said that it needs to be personalized, just because everyone has different types of requirements. For example, different people might have different types of goals, we might have different types of family responsibilities. So just having one intervention that is not personalized, it might not be able to, I guess, allow engagement between individuals and the intervention. The other part is the learning process. So we determined that from the 81 interventions, education was quite a significant, I guess, concept. So for interventions to work, it needed to, I guess, have a component of education in it. So to conclude the study, we determined the 6 possible hypotheses, and the 6 plausible hypotheses were then refined into our program theory. And hopefully that program theory will help us, I guess, construct an intervention that would be effective for healthcare professionals. And more specifically, the intervention should encompass tailoring or personalization and the learning process. Application to the critical care, yes, our initial intention was to cater the interventions to critical care healthcare professionals. However, due to the lack of evidence that is out there that caters to critical care, we were still able to, determine one paper which demonstrated that cognitive behavioral theory, mindfulness interventions, massage, yoga, and aromatherapy might be helpful. Yet again, future research is required on this subject matter, because we can't necessarily do an umbrella review on just one paper. So for future directions, we would want to do we want to probably validate or refine the program theory using an expert opinion, and probably make it into more of a realist expert opinion, and so that we can, I guess, refine the program theory to cater to critical care healthcare professionals. That's it for my presentation. Sorry that I was a bit long, but yeah, thank you. Any questions?